Hello, so good afternoon, and thank you for attending our HealthyU webinar series. Today's topic is COVID-19 fog is real, and our expert, Dr. Monica Verduzco-Gutierrez, will be talking to us about COVID-19, long COVID, and when you should see a doctor. Dr. Gutierrez grew up in South Texas, then moved to Houston, where she earned her undergraduate degree at Rice University, her medical degree at Baylor College of Medicine, and completed her PM&R residency training at the Baylor College of Medicine UT Houston Rehabilitation Alliance. She excitedly moved to San Antonio to lead the Distinguished Department of Rehabilitation and Medicine in 2020. Her area of clinical expertise is the care of patients with traumatic brain injury, stroke rehabilitation, and intraversional spasticity management. Most recently, she has developed a post-COVID recovery clinic to help those who were diagnosed with COVID-19 and suffer from various physical, cognitive, and functional difficulties. So welcome, Dr. Gutierrez.
Thanks for having me today. Very excited to talk about post-COVID syndrome and answer some of the questions that we got beforehand. So we'll talk about a lot of topics today, of course, touch upon brain fog, but also what are the symptoms in general that patients have when they've been struggling with COVID-19, have thought that they were cured of the disease, but continue to have some symptoms that are long-term, which is more than just the brain fog. And we'll go into that a little bit more. Now, this was an article that I was a part of early in the pandemic. There was specialists from 11 different countries, and we came together and wrote this manuscript to discuss, what are complications that we expect to see during a pandemic based on some other complications that had been seen in other smaller pandemics. And these were the main complications that we expected to see and that we definitely have seen. And these are also seen in patients who are hospitalized. So for the most part, in other pandemics, it's a little bit more severe patients and ones who had to deal with things like ongoing respiratory issues, shortness of breath, cognitive sequela, which is part of that is brain fogs, part of that is processing memory. There's also issues with the nervous system, whether that be central or peripheral nervous system. Patients who are especially in the ICU setting might get something called critical illness polyneuropathy or myopathy, where the nerves or the muscles are damaged after having a very severe illness. Of course, all patients could get deconditioned, whether hospitalized or not. Problems with swallowing, and we sometimes see that, especially if someone had a swallowing tube, a breathing tube actually down their throat, joint stiffness, pain, and then psychiatric problems like living with the effects and having maybe post-traumatic stress disorder or depression or anxiety after having critical illness. Something that maybe surprised us a little bit was we noticed that once patients had COVID, got over COVID, that they were having longer term symptoms after COVID-19. And of course, the pandemic hit first in China, then in Europe, New York, and then kind of moved its way here to South Texas. And so some of the literature comes more from Italy and the other areas. So in this one research paper, they looked at patients, most who had not been hospitalized or did not have that very severe disease, maybe only 5% needed some kind of help for breathing. And they looked at them 60 days after they had had COVID. And in this group of patients, 87% of patients still had symptoms. And the most common in this study were fatigue, dyspnea, which is shortness of breath, and joint pains. And then we were realizing there was ongoing symptoms even after you've gotten over the disease state. And then they were calling it long COVID for the long-term effects of COVID-19. And you can see kind of the symptoms were many across the board. But started to look at this more and more. There have been some online groups that have been doing their own research, and some groups, this one came from the University of Indiana, where they went into some of the Facebook and social media groups and went to the people who were on those groups. They were, self-proclaimed patients, suffering with the long effects of COVID and actually wanted to know what were the top symptoms that these patients still had. And so this was symptoms in 1,500 survivors of COVID. And of those people, 100% still had fatigue. The next most common things you can see, muscle and body aches, shortness of breath. The difficulty concentrating or focusing is in 59%, and that may sometimes be the fog that some patients feel. And then anything from also 45% had memory problems, difficulty with exercise, headaches, problems with sleeping, anxiety, and dizziness. Of course, you can see the list is very, very long. That's just kind of the tip of the iceberg, or some of the more common symptoms in 40+% of the patients that were in multiple patients who were in this group. One interesting thing that has also come up based on the literature is that they're looking at patients in this study who had had COVID-19, again, didn't have to be hospitalized. As we know, only a small percentage have the more severe disease or that have to be hospitalized. The vast majority of people are at home. So in this study, it was mostly non-hospitalized patients. They were in a clinic. They would go see a clinic afterwards in Paris, France. And most of them were 45-year-old females in this group. And so in a case of a lot of these patients, they got COVID, they were feeling better, maybe even feeling symptom-free for 20 to 30 days for a month, and then symptoms came back after the fact. And in 25% or more, they had new neurologic symptoms that they never had when they first had COVID. And so what were some of the late symptoms that they had? Major fatigue or exhaustion. And I see this a lot in my clinic. Patients are like, well, I had COVID, it wasn't that severe, I was feeling okay, and then it's really hit me down the road. Or they've had severe fatigue and it's just continued for this time. Neurologic symptoms, very, very common with this group of patients. And that's anything from, sensory disturbances, dizziness, numbness, tingling, and also the problems with brain fog. So again, 77% of patients, and actually more had these symptoms with long COVID than they did in the initial part of COVID. The other thing is cardiothoracic symptoms. So again, feeling tachycardia, which is when your heart is racing. So a lot of them will feel they get up and their heart races and goes up much higher than they'd ever experienced before. We also called that autonomic dysfunction or POTS or dysautonomia, or we have lots of fancy terms for that. I'll be answering a question about that later. They're having musculoskeletal pains, arthritis that got very bad, and joint pains. Ear, nose, throat symptoms. So that's anything from, and this is also stuff I see in my clinic a lot. Throat hurts, throat feels like it's burning, hard to swallow, voice changes, ringing in the ears. So those are some of the things we'll see with the ENT symptoms, also GI symptoms. So we know that diarrhea, nausea, vomiting, patients can get that early in the course of disease, but we've seen some patients have continued symptoms that way for a longer term, or have other GI complaints, abdominal pain, reflux, dyspepsia. And then skin and vascular symptoms. So things like, the skin changes, whether that be temperature, whether that be rashes, whether that be, changes in how it looks, and then also vascular symptoms. So some patients even down the line getting clotting later. So I'm out on the social media world and things that I learned from treating patients with long COVID. So everyone is a little bit different. Everyone had a different course. Some had very minor disease, some had more severe disease, but yet their long-term symptoms can affect them no matter how severe their disease was at the beginning. And we have to listen to their complaints and not blow off the complaints. These are real things. You've heard about a huge list of complaints that patients have, and they are real, and we have to acknowledge that, and including the brain fog, which is very significant for some patients. There's a lot of stressors going on as well. We're in a pandemic, times are rough, and the other thing is patients will get stress reactions to having these symptoms that no one understands, or if someone's telling them it's not real, when we know it's real, patients start feeling more anxious about it. And also they get worried about what could happen to them in their future. And then also patients are very grateful and very relieved to have someone listen to them, to have someone want to help them with the issues that they're having. So here, I am involved with other physicians that are colleagues from across the country, and we were noticing the disproportionate effect that COVID-19 was having on some underrepresented minority groups. And so we wrote a paper that was a call to action to specialists in our field to say, okay, we know that these groups are being affected more. We have to make sure that we're providing them rehab. And that was kind of one of the starts also for doing this post-COVID clinic in San Antonio, knowing that is we have a high Latino population, and this population was getting a lot of COVID. And so there was going to be a need. We saw the need that was happening in other parts of the country and other parts of the world, and said, let's create this coronavirus recovery clinic. And so here we are doing this work now since August of 2020, taking care of patients and seeing as many as we can. And there has been many at this point. So what is our COVID-19 recovery program? So we want to serve our population here and be able to give them the best type of treatment for any kind of symptoms that they're having after COVID-19 that affects their life, whether that be physical, whether that be mental, whether that be functional or social. Then, we want to meet those needs, and cognitive, including, if they're having the brain fog. And so we want to, help our community, serve them, and give them compassionate care in the field of physical medicine and rehabilitation. But it's not just me by myself. It is a team that I work with that is going to be able to, see the patients after the fact, after they kind of get screened and we realize what their needs are. And so for the most part, I'd probably say two types of patients that I'm seeing. In one group, we have the ones who are very severely affected, who had been hospitalized and had COVID pneumonia. Some had the medications, the treatments, the intubation, maybe some rehab, and they're very debilitated and have issues with breathing. Some of them went home on oxygen, and their muscles can be very, very weak. Or some of them have that critical illness, polyneuropathy or myopathy that I talked about earlier. And then there was the patients that only had mild to moderate disease. So they weren't ever hospitalized at all, maybe some ER visits, and they were told, well, you're not, sick enough to be admitted. And then they were at home, they were, were in quarantine there. Some of them didn't have, all the same treatments that someone might have that, we don't know if those treatments help outpatient settings. And so there isn't a lot of direction for them. They may have a lot of more worry. And then it's interesting the majority of the patients have mild to moderate disease. And so the most that we're seeing in my clinic have only had mild to moderate disease. So what do we treat? And some of the questions is also, what don't we treat? Because, we're willing to open the doors to patients that have their own symptoms, and they tell us about the symptoms they have. And some of it can be as severe as having a stroke, and some may be a little bit less. So maybe not, someone didn't have a stroke and they're just feeling fatigued, or they feel like they can't do the exercise they were doing before, or that they're have a hard time finding words and they feel a little foggy and they just don't feel like themselves. Some may have shortness of breath. Some may have, loss of smell and taste, or changed smell and taste that goes on for a long period of time. I think kind of the most recent data that's come out that for patients with long COVID is it's anywhere from 10 to 33% of patients that will have ongoing symptoms. Even at, study came out recently in the Lancet, 4 months, 7 months, they followed patients, mostly non-hospitalized patients again. And the most common symptoms in this patient population was fatigue, shortness of breath, loss of smell, loss of taste. So again, things that we've been hearing over and over again. And some of the risk factors to say, okay, what symptoms did you have at the beginning that made you at risk of having it down the line? So for that, it was probably ones who had multiple symptoms at the beginning. If someone had diarrhea at the beginning, and then also shortness of breath and loss of smell and taste at the beginning. So that told us, because those are some of the patients that are at risk of having it more down the line. And of course, we work again like with the team, as I said before, whether that be a therapy team or other specialists who need to see the patient, and we all work together. So community-based approach, we try to get to the patients as early and as often as possible. So if early means if you're one that was hospitalized, then we're going to our rehabilitation team in the hospital, try to see you there, try to be consulted when necessary, get physical, occupational, speech therapy to see a patient that early. Some patients may have required inpatient rehab if they were really off from their functional status. So those ones that were hospitalized, some will need home-based rehab, and we've made referrals to get patients home-based rehab because maybe they're so fatigued, so tired, it's hard for them to get out. The best thing is for someone to go to them. There's formal pulmonary rehab for those who have shortness of breath issues or who may have actual lung damage or interstitial lung disease or fibrosis from COVID. Autonomic reconditioning, that's a fancy term that we use for patients who have the POTS or the orthostatic intolerance. So that's the ones whose heart rates go up really high or their blood pressure may drop. And of course, this is also diagnosed along with our cardiology consultants and team who help us with this. And these patients need to recondition their system very slowly and while being monitored to improve that. And then we want people to, do as much activity and mobility and functional rehab. Again, not everyone needs formal therapy, but we need to start at least, trying to build a little activity. Some of the patients will have something called Post-Exertional Malaise or PEM. And what this means is a patient will try to do something or do more activity, and they'll feel okay doing it, but afterwards they feel really bad and they might feel more fatigued. And so I tell people it's like they're trying to do too much and they need to actually pace themselves or do some energy conservation techniques. So really starting slow with some of the activity that patients are doing. Provide a lot of education. I think if patients just kind of have some direction and know when to get help, and mental health services if needed as well. In the case of brain fog, it's tough because there is not a magic test that tells us, yes, you have brain fog caused by COVID, or no, you do not. There is not a CT scan that's positive. There's not an MRI scan that's positive. And a lot of these patients, they might get these and it might be completely normal, but that does not mean that they're not having the symptoms and they're not having brain fog. Brain fog is real, just as, we called this topic today. And in some patients, it may be they have memory lapses, they have a difficult time finding their words, they are just spaced out more, they have processing speed issues, attention issues, and this can be from a combination of factors. But like I said, I think we're still learning as we go. And some of it has to do with inflammation and the inflammatory cytokines and the changes that happen when someone had COVID. How did their immune system respond to it? And did that inflammatory chemistry, break through the blood-brain barrier and get in? And so it's a chemistry that your brain's not usually used to, having the inflammation around, which can cause some of the brain fog. And again, that's not something that we can see on a scan because it's not it's not a stroke, though some patients did have stroke, but in a vast majority of cases, it is not a stroke. And so it's hard to see something. There is formal testing that can be done, for example, neuropsychological testing to be able to see where people are. And then again, there's treatments for brain fog, including, working with speech therapy, occupational therapy, and neuropsychology as well. And both, restorative types of treatments and also helping people just make up for some of the deficits. So again, future research, working with many colleagues here at the Institute and outside the Institute. There's some post-COVID centers from 27 centers that are across this country that are working through my Academy of Physical Medicine and Rehabilitation. And we're putting our ideas and our numbers together and making consensus guidelines to help people across the country. We are looking at models of care, just like we have here in other places, and seeing how that can be put out in other places. Working with UT Southwestern to look at this as well. We're part of, we've submitted some NIH grants also to look at this and what's happening in South Texas. So what else? I very, very blessed to be able to, work with this amazing team and a lot of amazing colleagues to be able to say, not the only thing that changed was COVID, but what we did in medicine. So, a lot of our treatments had to go to telemedicine. I do a vast majority of some of my consults via telemedicine, and it's just very convenient for patients. And I can do some screening and some physical examination that well. We're looking at, also when it's difficult for patients to do telemedicine, sometimes there's some barriers we have to look at in that regard. So thank you for my team. These are some of the teammates that have either been working in the post-COVID clinic or starting some of our research together in our department, and very happy to be able to talk to you about this today. So now I will answer some of the questions that I got early on, which include, so we got a question from Lisa, and Lisa wants to know, is the numbness in my left toes and left finger related? And I will tell you that I don't know, is the easy answer, but there's definitely a lot of what's called paresthesias or numbness that some patients have. And there are different causes of numbness and tingling, especially in this population. And so a lot of times, if patients are having numbness and tingling, some of them will need a test called a nerve conduction or EMG test. And that might tell us a little bit more about if they're related or why is there nerve damage. And so again, that's more testing that would need to be done, but it may be related, especially if someone has a peripheral neuropathy, then it could be both. Jim asks, are statistics being generated that indicate percentages of people that have had COVID-19 and then exhibit symptoms of long COVID? So I did talk about this a little bit. I think we're looking more and more, and what we can find is, so if you're hospitalized, there could be a high rate of having long COVID. So there's some data that's showing that 66-70% of patients who are hospitalized will have symptoms. And then again, we're looking at the non-hospitalized, and anywhere from 10 to 33% of those patients. Of course, the vast majority of people were non-hospitalized. So those are the kind of numbers that we're seeing right now. So if you think about that, and the number of people who've gotten COVID, there could be millions of people who are suffering with long COVID. Joel here asks, what percentage of individuals, if infected individuals exhibit long symptoms, how many are associated with neuropathologies? So again, we talked about the percentage. Now about neuropathologies, I think it just depends on the studies that you look at. So again, anywhere of the long symptoms, 25 to 70% of some of the symptoms that people have are going to have neurologic symptoms. Now, what about, neuropathologies, meaning are you asking like, are we seeing stuff on their scans? Are we seeing abnormal test results? Then that number we don't have yet, though in some patients there are. And like I said, sometimes it's just a chemistry thing with the brain fog and we can't see it yet on standard imaging that we have. Next question from Ashley. Are there a large amount of people needing OT and PT services after being hospitalized and discharged from COVID? So the answer to that is yes. I will tell you, in our own clinic, where we're seeing the post-COVID patients, about 65 to 70% of the patients that I'm seeing have not ever been hospitalized. And about 75% were sending for ongoing therapy, that they need physiotherapy afterwards. So even ones who were not hospitalized are needing these treatments because of how they're feeling and because of their symptoms, whether that be, again, shortness of breath, debility, weakness, brain fog, their autonomic dysfunction or POTS. So, and then some are needing it, are hospitalized and needing it. Not everyone is getting it either. So again, it's sometimes an access to care issue. The other thing is, doctors don't have, all the patients don't have to come to the clinic. If a doctor sees a need, if a patient's really debilitated, then, you can get a referral from your primary care doctor to physical therapy. Some physical therapy places have open access, so you could even go and, get an assessment yourself, and they get a doctor on board to help continue your treatments if you do need it. From Michelle, how can someone build immunity after they have COVID-19? So we have our lovely immune system, and for the most part, our body will, recognize the foe that is COVID-19 and the spike proteins and build their own antibodies to COVID-19. And so in patients who've had COVID-19, everyone's immune response is different though. And then patients get antibodies after getting COVID-19, but some antibodies only last 3 months. Some will last 6 months or more. So everyone's kind of different on how long they have their immunity after having COVID-19. Question from Kuzama. What are the common post-COVID complications? Again, just a reminder, we did touch upon that, but fatigue probably being the number one thing, ongoing shortness of breath, loss, still abnormal or loss of smell and taste, not being able to do the same physical activity that you did before, the brain fog, and a whole list of other ones, but probably those are some of the ones in the top, 5 to 10. Lisa asked a great question. Is cognitive rehabilitation covered by insurance? And sometimes it depends insurance to insurance, but a lot of the insurers and the payers do cover speech therapy or cognitive rehabilitation. So it depends. If it's just outpatient therapy, then yes, for the most part, that kind of resource is covered. If someone needs more intensive, maybe a post-acute brain injury program for more severe brain fog issues, and it just depends on the payer if a more intense recovery program, brain injury type program is covered. Again, remember, before this, my day job was brain injury and stroke, and so I'm kind of very used to taking care of patients with brain fog, memory issues, and so it really depends on the payer and the needs. Okay, Walt asks, how does COVID-19 create blood clots? And a couple different things. First, COVID-19 causes endothelial dysfunction. Endothelial is a fancy word of saying our vessels. And so sometimes if our vessels are more inflamed, then that's going to create some reason for clots to happen. The other thing is that our blood might become a little bit more viscous. So that means, thickening of the blood. And then in general, clots can form with that. So there's it's this perfect storm. I know there's probably a more fancy way of explaining how COVID causes blood clots that is maybe better for a hematologist, but again, it's endothelial dysfunction, it's clotting that occurs because of the inflammation and the blood being thickened. Luce asks, what are the common after effects with COVID patients? Hand shaking, loss of smell, flat emotions. So this can definitely happen in some of the long COVID patients, all those things. And so, like I said, everyone's different. How we treat everyone, we kind of address each of those issues individually and see how we can help them. And so even if someone has loss of smell, we have some techniques, some treatments to try for loss of smell. If it's something like flat emotions, we have to look into that a little bit more. Is it flat emotions just on its own? Is it, is there some underlying depression that's occurred after the fact, which can, happen after having a very severe illness? And so those are some of the common after effects that, a physician would address. And yes, also handshaking or tremor could be one of those as well. We have a question from Tammy. Tammy says, what is the most common long-term COVID-related side effect, and can it be prevented or treated? So I think probably if we're looking at all the studies together, fatigue is the number one thing that patients have. Can it be prevented or treated? That is something that, we're still learning. Again, it depends. Everyone's system's different, and how everyone's system responds is different. So we don't know at this time. Is it going to be, well, we do know, I'm seeing more females in clinic. Is it, a certain age group? And we don't know, is it something with their immune response that they have this COVID related side effect? Is it something with their blood? Is it something with their activity level beforehand? These are all things we don't know why fatigue is there. Can it be prevented? Again, that part I don't know. Can it be treated? Yes, we have a consensus paper coming right out for fatigue, but some of it is, what I talked about earlier. If you're having fatigue, is energy conservation, and pacing. So that's telling people, okay, really don't overdo it. We want you to start doing activity. We have a quote that we say in our field, and that quote is, exercise is medicine. And even though maybe someone doesn't go right to full exercise, I want them to start doing some activity, but taking it really slowly and easily as they're getting back. So definitely, not just sitting out, but starting to do some really gradual activity. And that's something that helps in fatigue, as well as looking for underlying causes. So we have to make sure that, is everything okay? Are your levels okay? Just make sure nothing's, off from are you anemic, that sort of thing, that can, other causes of fatigue. Make sure it's none of that kind of more traditional causes of fatigue. And then just getting back to some cautious exercise. The other thing that I really am a big fan of is breathing. I know everyone's like, well, breathing, we're all breathing, we're alive, but we see that there is some breathing dysfunction after COVID, whether that be because our diaphragm muscle gets weak after illness and gets thin. It's a muscle, so it gets weak as well. And some of the patients really benefit from it. Breathing, diaphragmatic breathing, deep breathing, just starting with the basics. And because there are some studies that are showing that the patients may be kind of having a really short, rapid breath. So they're not taking their regular breaths, and this can make them more fatigued or feel short of breath as well. So we need to start with, yes, breathing exercises to help. And Anna says, are you looking to mast cell activation syndrome and POTS as a possible cause for some of the long COVID symptoms? So definitely there are some groups that are looking into this. I definitely think, mast cells are part of our immune system. It's in tissues all over our body. It's a part of our first line of defense. And so I do think as long COVID seems to be an issue with immune dysregulation and inflammation, then mast cells can definitely be involved in this as well. And so in some of my patients, we are talking about this phenomenon and what can be done if they, meet some of that criteria. So could it be tied in? For sure. More to come, more research needs to be done. But it may be why some of the treatments like Pepcid help early on in the course. As for POTS, I don't know if POTS is a cause for long COVID, or definitely long COVID patients will have POTS. So POTS, for those that don't know, postural orthostatic tachycardic syndrome. So, and there's actually a big kind of diverse spectrum of what this can be. So some will really have symptoms like if you're sitting, your heart, or laying down, your heart rate might seem normal. And then once you're up, so that's the postural, then the patient becomes tachycardic, which means their heart rate will go up 30 beats or more once they've been standing for a few minutes. And this can make someone feel really, really bad to stand if your heart rate's working really hard, or sometimes also your blood pressure drops. Someone's blood pressure may drop. And so there's some patients may just have an orthostatic intolerance, meaning it's hard to stand up. Maybe their heart rate doesn't go up that 30, but they still have a hard time when they're up and then we've seen blood pressure be up, blood pressure be down, because there can be a hyperadrenergic effect to it. And so our patients having POTS as long COVID for sure. And then, that would be another reason to see your physician. So you can get the education about how to be treated for COVID-19 or autonomic dysfunction after COVID. Next question from Dora. Do people get headaches that are worse than a migraine? And I think the answer is yes, all the above. There have been some studies that they've already looked at. What type of headaches are people getting with COVID or after COVID? So definitely we've seen headaches after the fact, and it can be very different, and they've been shown to be all types and kind of similar to other types. So people may have migraines. Some might have more severe, if their migraines were controlled, their migraines might get out of control. And then they need more treatment to help control their migraines. Some might have like sinus pain or frontal headaches. Some might have occipital neuralgia, which is going to be, pain at the back of the head. And some might have half of their head, and everyone's kind of different. Some may have, in some cases of headaches that are either new or way different, then imaging may need to be done. Because remember, COVID is a disease that causes thrombosis or clots, and we want to make sure that in some cases there's no venous sinus thrombosis that may be a cause of a very severe headache. So again, a reason to see your physician. We have some questions in the Q&A, so I will look. Now, we have one of the questions says, how long will these post-COVID rehab clinics be around, do I think? So I'm always hopeful that eventually I will be put out of business for this, meaning, do we get rid of COVID? People don't get COVID anymore. And, we get more answers about this and we can cure everyone. So again, that's a long-term goal, but hopefully they'll be around definitely in this next year, for the next couple of years. Patients are getting better and some patients still are not getting better. So it just kind of depends. And I think different studies show that. Like some may have a short course, 3 months they get better. Some it's already been a year or more and they're still feeling bad. So the post-COVID clinics may still need to be around to help address their needs for the long term. But hopefully as the cases go down and as more people are vaccinated, then we will not need these clinics. Next, are you getting an idea of how long brain fog lasts? Again, different on every single patient. Some are having that maybe more initially or in the first months of the disease. And I think as patients have COVID longer, then the brain fog may not last as long. Again, if it's an inflammatory thing, if it's a chemistry thing, how long does it take to kind of get our brain back online to where it was before? And then what kind of, whether it be restorative or compensation things can we do with therapy to help someone improve their brain fog to also decrease the symptoms as well? Next question, are you looking at experimental treatments like ivermectin for long COVID? So the question is, there are, some studies that are looking at it, and some studies have been more in the early setting and for patients that have had it either in the hospital or right after they've gotten COVID. There's some studies that look at it long term. And so definitely I would say it's something that, I keep my mind open to, even though maybe not all the studies are there, but if you're my patient. We talk about it in an individual level, and also we consider other treatments as well. And again, everyone's an individual. We consider different things. We weigh the pros and the cons based on, the time that it's been, everyone's individual treatments, what their symptoms are, and go from there. Let's see, chat. Does COVID, another question we have, does COVID-19 cause autoimmune? And I think the answer to that is maybe. I think that in some patients, or there's been a study where they look at auto antibodies, patients' own antibodies, and if you were just to take a random patient population and check them for antibodies, autoantibodies, the number would be very low. But they're checking it in some post-COVID patients and finding antibodies to be positive in more of those patients than you would expect in the general population. In some patients as well in our long COVID clinic, we are checking for these types of things, especially if their symptoms may match up with some more traditional autoimmune conditions, and looking for it. And in some cases, we have found some autoimmune antibodies in some of the patients that we have. And so, it's something that, again, individualized, and it's something, I feel that it's inflammation, it's immune changes in someone's system. It may trigger something that they may had a propensity to before that's autoimmune. And so if so, you need to treat the condition that it triggers as well. Next question from Jim. Do prior comorbidities play a role in the symptoms attributed to long COVID? I don't know if I have a good answer for that, but I think one thing is most of the patients who have long COVID are women and who are in their middle age. So like 40-year-olds, 45-year-olds, 48-year-olds, and women more than men. I think if you look at who gets regular COVID, it's men get it more, older people get it more, people who have other risk factors like overweight, comorbidity, asthma, lung transplants, people who are not that active. So I don't think we have a good idea yet of, what are the risk factors, if people have risk factors for getting it down the line, though we're starting to learn more about, okay, which symptoms, once they get COVID, will make them at risk of having long COVID later. So hopefully more to come with that. And also, I wanted to say that thank you for coming to this talk to learn about long COVID, to learn about brain fog. Hope you felt that you were educated and learned some, and that we do have a winner for one of the attendants of this program, and that is Ellie Mendiola. And we will get to you, Ellie, and send you your prize. So thanks all for being here today.